Hello and welcome to Pediatric GI Lectures. Our talk today will be about malabsorption. First of all, I need to get your attention to misconception. Chronic diarrhea is not always a malabsorptive disorder, and at the same time, malabsorption may not present with chronic diarrhea, maybe can present even with chronic constipation. Let's talk about the epidemiology and pathophysiology. As you all know from your physiology, that nutrient absorption is an efficient process that is regionalized in the gut and depends on pancreatic secretions, hepatobiliary secretory functions, and the mucosal integrity of the intestine. So you need all these things at the same time to work to have an efficient absorption. And at the same time, you need a very important part, which is the gut motility. We need to have a normal gut motility and intact at the same time lymphatic and venous drainage to uptake those nutrients inside the body to the liver. Neonates and young infants have a reduced ability to digest fat, so still you can see fat droplets when you are testing for stool for fat in young infants, which is still normal. As we said, coordinated intestinal peristalsis is important in facilitating digestion. So children with abnormalities for their gut motility would have an impaired type of absorption. Still, preterm infants, very ill children, they have reduced motility, and you need to expect that those patients might have an element of malabsorption. The digestive absorptive process categorized into interluminal, which is dependent on the pancreatic and the biliary secretions. The second phase is the mucosal, which means that you need the villi, microvilli, and the brush border enzymes to be all in harmony and working. And the third phase is the venous and lymphatic transport phase. And you need to remember that most nutrient digestion and absorption occurs in the proximal small intestine. Let's talk about a couple of malabsorptive syndromes. First of all, let's have a peek on disorders. As you all know, that cystic fibrosis is the most common cause of pancreatic insufficiency in children. And I'm pretty sure you have details of this disease during your respiratory course. So cystic fibrosis is a hereditary disorder characterized by recurrent pulmonary infections, malabsorption of nutrients due to the pancreatic insufficiency type. Another disorder with pancreatic insufficiency is Schwachman-Diamond syndrome. This is an autosomal recessive disorder, affects almost 1 in 10,000 live births with atypical phenotypic features. Patients with Schwachman-Diamond syndrome are short, they have skeletal abnormalities, they complain also of recurrent infections due to the immune deficiency state of them that they have, in addition to multiple features of bone marrow dysfunction, like cyclic neutropenia or even pancytopenia. Schwachman-Diamond is considered a pre-leukemic state, so those patients need a close follow-up for the development of leukemia. In comparison to the pancreas of patients with cystic fibrosis, the pancreas in patients with Schwachman-Diamond have pancreatic lipomatosis leading to insufficiency compared to the fibrosis that occurs in patients with cystic fibrosis. Let's take a glimpse on some hepatic disorders. The presence of bile in the lumen of the intestine is of major importance for the fat digestion and absorption. Chronic cholestasis, which is delayed excretion of the bile salts into the intestinal lumen, could cause growth failure, chronic malnutrition, and fat-soluble vitamin deficiencies. Please remember that chronic cholestasis usually is coupled with jaundice, but it's not mandatory. Most of the time, we think about cholestasis when the patients are yellow, but this is not the case all the time. Fat-soluble vitamins are dependent on the intact absorption of the fat to get absorbed. As you know, vitamin K, vitamin E, vitamin A, and D are the fat-soluble vitamins. Vitamin K, for example, is very important for the hepatic synthesis of coagulation factors, mainly the extrinsic pathway. So in case those patients have vitamin K deficiency, you would find a prolonged PT and very high INR if you test them. The second vitamin is vitamin E. And vitamin E is important because it has an interrelated digestive steps necessary for absorption. So the absorption of vitamin E is somehow a complicated issue. And the manifestations of vitamin E deficiency are both neurological and hematological. Those patients might manifest like ataxic, decreased, or even absent reflexes, ocular palsies, and they might present with hemolytic anemia. Have a look at this eye and try to link the feature you are seeing with a vitamin deficiency. Okay, so this is keratomalacia secondary to vitamin A deficiency. The second manifestation of vitamin A deficiency is night blindness. بالعربي العشاء الليلي. One more fat-soluble vitamin that could be deficient in patients with fat malabsorption, which is vitamin D. The famous name, rickets. You can appreciate in young children some softening of the bone of their skull. You can see the bony necklace, which is the expansion of the costochondral junction. The other name is rosary beads. You can see abdominal distension, hypotonia, curved bones, both legs if the patient is walking, and big lumpy joints. If you do an X-ray, especially or usually what we do is the left wrist X-ray, you can see that the bone are rarefied. You can see the joint space expanded. You can see cupping and fraying of the bones. Other causes for persistent cholestasis during early infancy, mostly related to biliary atresia. Those are patients usually picked after having prolonged jaundice during their neonatal period. And those patients should undergo CASI procedure, which is the hepatoportoenterostomy, to divert the bile, to allow the bile flow, cause of the atretic, usually common bile duct. Other rare conditions, syndromic or either related to specific inherited bile duct epithelial transport defect, could cause it also, the persistent cholestasis during infancy. Here you can see one of the congenital causes for cholestasis. This is an autosomal dominant disorder those patients will have broadened forehead, pointed chin, elongated bulbous nose. Usually those kids would have malnutrition and growth failure due to the fat malabsorption. During their eye exam, you can find posterior embryotoxin. If you auscultate their heart, you would hear a murmur of peripheral pulmonic stenosis. Skeletal abnormalities, if you do a spine X-ray for those patients, you might find butterfly vertebrae. Neurological-wise, they are not mentally retarded, but they have some learning disabilities in addition to renal and vascular abnormalities. So those are the features of Alagille syndrome. Let's talk about mucosal surface injuries as a cause for malabsorption. The classical disease is celiac disease. Okay, celiac disease is a progressive inflammatory damage to small bowel mucosa, which is an autoimmune phenomenon, with enteritis appearing to be most severe proximally. So the duodenum is affected more than the jejunum, and more than the ileum, and even the terminal ileum is reserved in those patients. This map is showing the world distribution of the prevalence of celiac disease. So you can see that there is worldwide increasing incidence. The frequency is between 1 in 100 to 1 in 500. And I hope you can appreciate that in Algeria, for example, it's 1 in 70. Celiac disease appears in genetically susceptible individuals who sustain an autoimmune reaction to the toxic gliadin protein fraction of gluten. More than 99% of celiac patients are HLA DQ2 or DQ8 positive. Those are the grains. Regarding the clinical presentation of celiac disease, when I was at your age, we were taught that celiac disease is a pediatric disorder presenting with what you can see in this picture. Young infant with butt belly, which is abdomen distension, wasted extremities, bulky stools, irritability, and have a laboratory evidence of malabsorption. This is the classical presentation. Nowadays, we know that even those patients, up to 30% of patients with celiac disease, would present with constipation rather than diarrhea. Still, there is more subtle presentations and even asymptomatic forms and delayed onset of the disease up till late adulthood. Patients with celiac disease manifest other manifestations that are extraintestinal. For example, peripheral neuropathy secondary to B12, B1 deficiency, and also the vitamin E deficiency that we were talking a couple of slides about. Anemia. The most prevalent type of anemia in patients with celiac disease is iron deficiency, which is hypochromic microcytic. But those patients might present with dimorphic type of anemia secondary to both iron deficiency, giving the microcytosis, and vitamin B12 and folate deficiency, which gives macrocyte also, giving this anemia her name as dimorphic type of anemia. Growth failure, we know those patients have fat malabsorption in addition to losing their proteins, and also bone pain secondary to osteoporosis and osteopenia, vitamin D deficiency and calcium deficiency, muscle cramps, electrolyte deficiencies, night blindness, we talked about vitamin A deficiency before, weight loss secondary to the impaired absorption, edema, those patients are hypoalbuminemic, which might lead to edema, weaknesses, hypokalemia, and electrolyte depletion. There's an entity in patients with celiac disease called celiac crisis, when they have severe watery diarrhea associated with severe hypokalemia, acidosis, and severe abdominal distension. Bleeding and hematoma, we talked before about the vitamin K deficiency. Other extraintestinal manifestations that they are not secondary to malabsorption, like neurological disorders. It is linked already, celiac disease, with depression, epilepsy, migraine, ataxia, and even occipital calcifications. Dermatitis herpetiformis, which is severe itchy nodules in the extensive surfaces, and if you took biopsy from them, you will find the deposition of the antibodies in the skin of those patients. Elevated liver enzymes and liver failure, infertility, especially in females, stomatitis, IgA nephritis, myocarditis, pulmonary hyperstenosis, and even you can find arthritis. So this is the picture of dermatitis herpetiformis. So this is a very itchy type of rash, and usually those patients will resolve their symptoms, the skin symptoms, if they started treatment for celiac disease. This is the celiac disease iceberg. So the idea that what we see as classical and non-classical celiac disease is just the tip of the iceberg, where the patients are manifesting their symptoms. Below the level of the C, or in the shadow, is the silent celiac disease. Those are the patients who don't have symptoms, but they have abnormal serology and abnormal mucosa. And there is a huge bulk of patients called the latent celiac disease who are genetically susceptible. They have DQ2, DQ8 positive, and they are waiting for the appropriate hit to enter into a celiac disease status. Again, this is just description for what types of celiac disease we're talking about. You need to remember that specific populations, they have increased incidence of celiac disease. Like other autoimmune disorders, type 1 diabetes, autoimmune thyroid disease, rheumatoid arthritis and other vasculitides, and autoimmune liver disease, in addition to specific syndromes. So if you look at the left side hand of the slide, I hope you can appreciate that this patient is having Down syndrome. Okay, so the left hand side, Down syndrome. The right hand side of the slide, I hope when you look at this is a female with a webbed neck. So this is a Turner syndrome. I will leave the one in the middle for you to comment what type of syndrome is this patient is having. Looking for the evidence of celiac disease, what you can see is a complex type of anemia. We talked about the dimorphic type of anemia. You can appreciate a malabsorption of fat-soluble vitamins like prolongation of the INR, features of rickets, eye manifestation, neurological manifestation of vitamin E, hypocalcemia, for example, hypoproteinemia, as we said, that those patients have an element of protein-using enteropathy plus the malabsorption that they have. Fecal alpha-1 antitrypsin elevated. Just a couple of words about the fecal alpha-1 antitrypsin. Alpha-1 antitrypsin as a protein is a protein that is not found in diet and it will not be digested. So if you find the alpha-1 antitrypsin in the feces, this means that this protein is leaked through the gut, which means that you have a non-intact type of mucosa or loss of the mucosal surface. بالتالي هذا البروتين يعني بمعنى آخر برشق من البادي into the intestine، وهذا معناته إنه الميوكوزال phase of absorption اللي كنا بنحكي عنه بأول slides is impaired، والclassical type of this malabsorption اللي هو mucosal type is the celiac disease. What about screening test for celiac disease? Anti-endometrial antibodies IgA والanti-TTG أو tissue transglutaminase 2 هم الموست sensitive and specific. في specific entity لازم نتذكرها إنه IgA deficiency is associated with increased incidence of celiac disease. طيب إذا بعت أنا anti-endometrial antibody IgA أو TG2 IgA والمريض عنده already IgA deficient, I would not find those antibodies, so راح يطلع negative. وهذا هو نسميه false negative بهدول المرضى تبعون celiac disease. So what should I do? I should send IgA level in each patient I'm testing for anti-endometrial antibodies or anti-tissue transglutaminase IgA. لازم يكونوا coupled with the total level of the IgA. إذا طلع المريض عنده deficiency بال IgA تاعه معناته my test is not reliable and I need to look for another test, either to do IgG of the anti-endometrial أو TTG أو ممكن to go for endoscopy إذا ما كانش برضه conclusive. Antigliadin antibodies have no role in screening, diagnosing, following patients with celiac disease. هدول التست opposite. How can I diagnose a patient with celiac disease? First of all, I need signs, symptoms consistent with celiac disease. نتذكر, I'm not just looking for diarrheas in those patients. Sometimes it is more of just short stature, or patient is having severe intractable type of constipation. Positive serology testing with the anti-endometrial antibody IgA أو TTG IgA positive. Then you need to do upper endoscopy and take duodenal biopsies. واحنا هنا بنحكي عن الجولد ستاندرد تاعي. الجولد ستاندرد تاعي هو انه to take intestinal biopsy, واكيد انتم تعلمتوا during your pathology courses الشيء اللي نسميه المارش كرايتيريا, وانه انت تدور على total او subtotal villus atrophy with intraepithelial lymphocytosis. هذول suggestive of or consistent with celiac disease. Then you need clinical remission after withdrawal of gluten. لما نشيل عن الجلوتين من الدايت تبعهم المرضى المفروض ان السيمتومز تاعتهم to improve, and with time you would see circulating antibodies اللي كانوا positive بالبداية they started to turn into negative. So the gold standard is small intestinal biopsy to confirm mucosal damage بهدول المرضى. So again, this is the Marsh criteria. I'm not after memorizing them, but I need you to remember the picture. So the left-hand side, you can see a nice projections villi with a very good proportion between the villus size and the crypts, while in the right-hand side, you can see there is no villi, and at the same time, there is dense lymphocytic infiltrate with hyperplasia of the crypts. So this is a celiac disease patient. Treatment: celiac disease patients should not get any gluten. So celiacs should go gluten-free. You need to remember, partial non-compliance is associated with increased risk of cancer and extraintestinal medical problems, specifically, even if there are asymptomatic, specifically the osteoporosis. So how to evaluate a patient with suspected malabsorption? Those are the charts from one of the articles in the pediatric review. So you need to take a detailed history and physical examination. You need to prove that this patient is failing to thrive or failing to gain weight by having a serial plotted points on the growth chart. You need to remember that one single point is not enough to diagnose that this patient is not growing well. Complete blood count and DSR. You can see those patients might be anemic, lymphopenic, neutropenic, thrombocytosis with the anemia, or thrombocytopenia with some immune deficiencies. ESR can give you a picture about the inflammation, For example, patients with IBD would have high SR. Chemistry panel, albumin is very important. Total protein is very important for you. Liver enzymes, in case suspecting the patient is having cholestasis, for example, and even patients with celiac disease might have elevated liver enzymes. Calcium, phosphorus for surrogate markers for the vitamin D deficiencies. Other electrolytes, we said that patients with celiac disease might have celiac crisis with severe hypokalemia. Bilirubin, as we said, bilirubin total and direct will guide us if we're talking about cholestatic process. Examination of stool and test for occult blood. You need to remember that the examination of stool might give you a clue regarding some infections. For example, giardia can give you a malabsorption picture, although this is an infectious process. Presence of blood in stool, again, IBD, for example, is one of your differentials. You need to remember, especially if you are talking about toddlers, the presence of food particles, undigested food in their stool is a normal phenomenon. Okay. Okay, inflammatory bowel disease panel, the ANCA and the ASCA with other type of antibodies. The diagnostic value of those tests is very low. Actually, you can use them only to differentiate between UC and Crohn's disease rather than to diagnose one of them. CELIAC screen, including the TTG or anti-venezial and the IgA level if you are suspecting that the patient is having celiac disease. Cystic fibrosis, DNA mutation, because we are talking here about the blood tests, although you know that cystic fibrosis, the most reliable test is doing sweat chloride on those patients. Vitamin levels, if you can do, especially vitamin D, for example, B12 and folate, fat-soluble vitamins, prothrombin if you are suspecting vitamin K. What you can do in the stool analysis, you can do fecal alpha-1 antitrypsin, as we said before, stain for fat. This can give you a clue, Sudan 3 or Sudan 4, that there is undigested fat in the stool. Stool trypsin, or stool fecal elastase would help in patients with pancreatic insufficiency. Stool pH, or looking for reducing substances if you are suspecting carbohydrate malabsorption like lactose intolerance or lactase deficiency, you would find the stool pH is low, acidic stool with positive reducing substance. Other tests, as we said, the sweat chloride if you are suspecting cystic fibrosis. You can do hydrogen breath test for the carbohydrate malabsorption. So if you are suspecting specific sugar the patient is not digesting, you can give this patient this sugar, and then you will collect the breath. You know, undigested sugar will be fermented by the gut microbiota, so this will release the hydrogen. So if you find a very high level of hydrogen in the breath of this patient, then you can say that this patient is having malabsorption of this sugar. You can do it for the sucrose, for the lactose, and even you can do it for the lactulose, which is a synthetic sugar اللي احنا بنستخدمه as a cathartic بنعطيه للمرضى اللي عندهم chronic constipation. And if you find in the patient عنده very high level of H2 after taking the lactulose, this is an indirect marker of bacterial overgrowth syndrome. So definitive testing ممكن gastrointestinal endoscopy و taking biopsy، وممكن انه انت تستين الانتستينال بايوبسي او نحكي دودينال بايوبسي خلينا نحكي عشان تطلع على المارش كرايتيريا موجوده ولا مش موجوده. ممكن تعمل سبيشال ستينز فور سبيسيفيك مايكرو اورجانيزمز كان في عندك هاي سسبشن زي جياردياسيس او كريبتوسبوريديوم اذا المريض عنده اميون ديفشنسي. If you are thinking of disaccharidase deficiencies او brush border enzyme deficiencies, you can take الدودينال بايوبسي وتخبر البايكيم لاب تاعك انك انت بدك تجيب لهم فريش بايوبسي بالانتستين و they can measure level of the enzymes بهذه البايوبسي. يعني هذا مش بتحطها بفورمالين وبتبعتها للمختبر الهيستوباثولوجي، احنا بندور على functional assay وهذا الشيء موجود. electron microscopy looking for ultra structure، وهذا بيفيدنا بالذات بالمرضى اللي عندهم تفتنج ايتروباثي او مايكروبيلس انكلوجن ديزيز، وهذول الاشياء اكيد تعلمتوا انتم بالباثولوجي كورسز تاعتكم. اي ار سي بي اذا انت بتفكر في انه والله you can visualize البنكرياس، مريض عنده recurrent pancreatitis، او you can برضه diagnose اذا في عندي obstruction بالبلياري تراكت تاعي. pancreatic enzyme analysis، وهذا يعني very specific maneuver انك انت you will do endoscopy، you cannulate الامبولا فاتر، تعطي something to release الكونتنت تاعت البنكرياس، you will collect that and then you will measure level of enzymes، وهذه بمعنى آخر pancreatic function test. انت you collected السكريشنز تاعت البنكرياس، فحصت الليفل تاعهم انه موجودين هذول الانزيمز ولا مش موجودين. الليفر بايبسي ممكن تفيدني اذا مثلا انا شاك بانه المريض عنده biliary atresia فور اكزامبل، او اذا كان المريض انت شاك انه عنده الاجيل سندروم، تعطيني فكره عن بهذول المرضى. imaging studies زي liver scan او الهايدا سكان، وهذا كمان it will correlate مع biliary atresia، انك انت تعطي radionuclide material وبتشوف هذه be uptake by the liver بعدين excreted in the intestine. اذا لقيتها بعد فتره معينه موجوده بالانتستين معناته انه الطريق تاعتها فاتحه، معناته الكومن بايل داكت تاعي هذا مفتوح، وهذا excluding biliary atresia. lymphatic scan اذا انت شاك انه في عندك lymphatic problem زي الليمفانجكتيزيا، تعطيها الماتيريال ممكن تلاقيها dilated او collected بسايد معين اذا في عندي انا lymphatic obstruction. CT of the liver and the pancreas بمرضى مثلا زي مرضى الشواخمان دائما هذول ممكن تشوف على السي تي انه في lipomatosis of the pancreas. في واحد جزء من الموضوع احنا ما حكيناش عنه اللي هو malabsorption and chronic diarrhea secondary to surgical causes، زي مثلا المرضى اللي عندهم marotation او المرضى اللي عندهم stenosis، هذول بصير في عندي انا blind loop dilated، هذا اللوب بينتلي بكتيريا، البكتيريا هذه بنسميها بكتيريا overgrowth syndrome، وهذول it will denature the bile salts for example. من جهة ثانية they will lead to malabsorption. هذول عشان نشخصهم بدك upper GI series، يعني تعمل barium meal with full of through، فبتقدر تشوف انه والله هذه الاشياء موجوده. بتقدر تشوف فيها برضه الليمفانجكتيزيا، يعني ممكن تشوف الليمفانجكتيزيا، ممكن تشوف يعني الفيتشرز على الليمفانجكتيزيا، اذا في venous obstruction، اذا في عندي blind loop، اذا في عندي stricture موجود، هذول كلياتهم راح يبينوا على هذا السكان تاعك. و thank you.